Hi guys, and welcome to our model on the esophagus. The esophagus is a fibromuscular tube extending from the neck down to the abdomen. It is located within the thorax, hence the reason why we're talking about it in this model, and it tends to be found sandwiched between the trachea in front, and the heart also in front, and then the vertebrae behind. Now, the sole function of the esophagus is for the passage of food and liquid from the oropharynx to the stomach. When we swallow, food tends to pass all the way down from the throat into the esophagus, and then from the esophagus down to the stomach where it will be digested. So, the function of of the esophagus is largely for the role of motility and movement of food towards the site of digestion. In terms of dimensions, the stomach is said to be measuring about 25 centimeters in length and about 30 millimeters in diameter. That 25 centimeters sometimes is converted into inches, so we tend to remember it as 10 inches or 25 centimeters. Let's talk quickly about the origin, the cause, and determination of the esophagus. So, in terms of its extent, it tends to begin just directly below the cricoid cartilage, said to arise at the lower border of the cricoid cartilage, similar to where the origin point of the trachea is. And that point is usually at the level of the sixth cervical vertebrae. It then begins to descend through the neck and then from there enters into the thorax and then eventually ends in the abdomen. So you see the esophagus tends to have three major parts to it: the cervical part, the part within the neck; the thoracic part, the part within the thorax; and the abdominal part, the part in the abdomen. It's is in terms of its origin, it's continuous superiorly with the laryngeal part of the pharynx. So in terms of the course of the esophagus, once it originates from the lower border of the cricoid cartilage, it descends through the neck and then into the thorax. Our major focus is on its course within the thorax. When it's within the thorax, it first of all tends to be located in the superior mediastinum of the thorax. In this superior mediastinum is found between the trachea anteriorly and the vertebral bodies of the first to fourth thoracic vertebrae posteriorly. And then it crosses the imaginary line separating the superior mediastinum from the inferior mediastinum and then enters into the posterior mediastinum. So within the posterior mediastinum, as it descends, the esophagus tends to be found behind the heart and in front of the fifth to 10th thoracic vertebrae. Finally, once it gets towards the ending of the 10th thoracic vertebrae, where the diaphragm is, it pierces through the diaphragm through an opening known as the esophageal hiatus, and then it gains entry into the abdomen. And within the abdomen, it tends to terminate. It runs a very short course within the abdomen. So within the abdomen is just a short part to the esophagus, and that short part tends to extend from T10 down to T11, and then eventually it ends by continuing as the stomach. So along the length of the esophagus are two important structures known as sphincters, and we have the sphincters tend to guard the entry or exit of structures through the esophagus. So we have one at the starting point of the esophagus known as the superior esophageal sphincter, or we call the upper esophageal sphincter, and then we have one towards the ending of the esophagus known as the inferior esophageal sphincter or lower esophageal sphincter. So the superior esophageal sphincter tends to separate the esophagus from the pharynx above it, and it guards the entry of fluid or food content into the esophagus. And then the lower esophageal sphincter or the inferior esophageal sphincter tends to guard the entry of the or the exit of the esophagus, and then tends to prevent food or fluid from entering from the stomach back into the esophagus, what we know as reflux. So the superior esophageal sphincter or the upper esophageal sphincter is located just at the level of the cricoid cartilage at C6. And like I said, it tends to guard the starting point of the esophagus. It is formed largely by the cricopharyngeal muscle, and it is the site for one of the constrictions of the esophagus that we'll talk about in the next couple of slides. For the inferior esophagus, it is located at the level of the cardiac of the stomach at the 11th thoracic vertebrae. and that serves as the junction between the stomach and the esophagus, what we know as the gastroesophageal junction. And it is formed by a circular muscle of layer of tissue that is found at the junction. And unlike the superior esophageal sphincter, the inferior esophageal sphincter is considered as a physiologic sphincter, meaning that anatomically or structurally, it is not formed by the muscle that tends to guard that entry or exit points. It's a physiologic sphincter because of the fact that the muscle that is found, although there's a muscle there, circular muscle there, the muscle is not an actual sphincter like you would see in every other site. The muscle, based on how it is positioned and where it's positioned, tends to act as a physiologic sphincter and not structural sphincter. Let's talk about the constrictions of the esophagus. There are four major points where the length of the esophagus or the diameter of the esophagus tend to be narrowed. And these 4 points tend to go from superior to inferior. As first of all, the first point being the cricopharyngeal muscle, the second point being at the level of the arc of aorta, the third being at the level of the bronchus, and the fourth being at the diaphragm. And you can see images of each of the constrictions here. The first constriction at the level of the cricopharyngeal muscle is just at the same point where we have the upper esophageal sphincter. Then at the middle point, the middle constriction is done occurs by two different structures, or is found at the site of two different structures. The aorta are shown here, and the bronchus are shown here. So these two major structures tend to lead to a middle esophageal constriction. And then finally, the last constriction is at the point where the esophagus passes through the diaphragm to enter into the abdomen. That's at the esophageal hiatus, and that's the lower esophageal constriction. We'll also tend to talk about the esophageal constrictions in terms of their length, or better still, in terms of the distance of the constrictions from the incisor tip and tooth. So when we are measuring the distance from the incisor tooth to the constriction, the very first constriction formed by the cricopharyngeal muscle tends to measure about 15 centimeters, or about 6 inches from the incisor. When we drop down to the constriction done by the aorta, that is about 9 inches, or about 22.5 centimeters from the upper incisor, usually at the level of T4, T5. For the cricopharyngeal constriction, that one is at the level of C6. Then when we drop down to the constriction done by the bronchus, that measures about 11 inches, or about 27.5 centimeters from the upper incisor, and tends to be at the level of T5, T6. And finally, the last constriction at the diaphragm is going to measure about 15 inches in length, or sometimes 16 inches in length, or 40 centimeters in length from the upper incisor. And that's at the level of T10, where the esophagus tends to move from the thorax into the abdomen. Let's quickly talk about some of the relations of the esophagus. We'll talk about the relations of the esophagus that pertains to the cervical part and the thoracic part of the esophagus. On the cervical part of the esophagus, anteriorly we have the tracheae and the right and left recurrent laryngeal nerves being related to the esophagus. Posteriorly, we have the longus colli muscle and the vertebral column. From the usually the cervical vertebrae tend to border the esophagus posteriorly. And then laterally, we have the lobes of the thyroid gland and the thoracic duct on the left side, flanking the esophagus. In the thorax, the relations of the esophagus anteriorly includes the trachea, the left bronchus, the diaphragm, and the pericardium and the heart. As you can see in the image here, you see most of those structures there. Posteriorly, we have the thoracic vertebrae, from the first down to the 10th thoracic vertebrae, the thoracic duct, the azygos vein and the tributaries, and then the descending aorta. Still within the thorax, in terms of the relations on the left and the right side of the esophagus, to the left of the esophagus, we have the left subclavian vein, the aortic arc, the left recurrent laryngeal nerve, the thoracic duct, the left pleura, and the descending thoracic aorta. On the right side, we have just very few structures there, the right pleura being among, and then the azygos vein. So let's talk about some of the blood supply to the esophagus. The blood supply to the esophagus comes in the fashion of a number of different arteries depending on where the esophagus tend to lie. So within the cervix or within the neck or of the body, the esophagus tends to be supplied by the inferior thyroid vessels, particularly the inferior thyroid artery. Um, when we drop down to the thorax, it's supplied by the esophageal branch of the thoracic aorta, and then the part of the esophagus that is found in the abdomen is supplied by the left gastric artery. In terms of venous drainage in the neck, the esophagus is supplied by the inferior thyroid vein. In the thorax, we have it supplied by the esophageal branch of the zygous vein. And then at the abdomen, that's very small section of the esophagus tend to receive dual supply, one from the portal vein, coming from the left gastric vein, branch of the portal vein, and then one from the systemic circulation coming from the left gastric branch of the IVC. And each of these veins tend to anastomose together to form part of the portosystemic anastomosis, which is the concept we'll talk about in a separate module under abdomen. The esophagus is supplied by a number of nerves. The nerves tend to be a combination of sympathetic and parasympathetic nerve. The parasympathetic component that supplies the esophagus is the vagus nerve, and we have a right and left vagus nerve that flanks the esophagus at the side. Then we have the sympathetic component of the esophagus being supplied by the greater splenic nerve. And then finally, we have some enteric nervous system found within the tissue wall of the esophagus. We'll talk about some of this, but they include the Meissner's plexus and the Alpers plexus. The lymph within the esophagus tends to be drained to a number of lymph nodes. This includes the deep cervical lymph nodes in the neck. In the thorax, it includes the superior and posterior mediastinal lymph nodes, and then in the abdomen, it is drained by the celiac lymph nodes. Let's jump to the embryology of the esophagus. The embryology of the esophagus is very linked to the embryology of the trachea that we talked about in a separate model. The esophagus begins from or is formed from the embryonic foregut, which is a singular structure, singular tubular structure gotten from endodem. Usually, when the esophagus begins to develop, what occurs is that at the fourth week, we see an outpouching known as the respiratory diverticulum emerging from the foregut are shown here. So this image here that you are seeing here on the yellow tube is the foregut, and then the blue tube popping out of that yellow tube is the respiratory diverticulum. So with time, the respiratory diverticulum tends to separate from the foregut. And usually how it tends to do that is, first of all, a ridge tends to emerge in between the foregut and the respiratory diverticulum, and that's called the tracheoesophageal ridge. And that ridge would eventually merge together to form a tracheoesophageal septum, and then eventually divide the foregut into a ventral trachea and a dorsal esophagus. So as I said before, once the foregut begins to develop around the fourth week, we have a tracheoesophageal ridge or fold forming in between the respiratory diverticulum that has popped out of it and the foregut itself. And then the edges of the tracheoesophageal fold would meet, forming a tracheoesophageal septum and dividing the foregut into a ventral trachea as shown in blue and a dorsal esophagus as shown in yellow. This occurs around the 26th day of gestation. The trachea would eventually give rise to long boards that go ahead to form the respiratory system. The esophagus behind would now further develop as we'll talk about in the next slide. So initially, the esophagus tends to be short, but with time it tends to lengthen and then descend um, across the entire thorax with the heart and the lungs. During development, we have first covering the endodem of the esophagus, proliferating and then occluding the lumen. So initially, we start with a very hollow tube, which is formed from the foregut, which eventually divides into a ventral trachea and a dorsal esophagus. That tube becomes obliterated by the presence of proliferating endodermal cells, as shown here. You can see how the entire lumen is obliterated, and then with time we start to see that the solid endodermal structures that obliterated the lumen begins to recanalize, and the recanalization tends to occur, creating a new lumen at the end of the day. So usually the recanalization there allows for the esophagus to be patent, and as a result allowing for food passage to occur. If recanalization fails, this could lead to a number of defects, usually one of which tends to be an esophageal atresia or esophageal stenosis. Let's talk about the histology of the esophagus. The esophagus is made up of four layers of tissue from outside to inside. They include the mucosa, the submucosa, the muscularis externa, and the adventitia. The mucosa is the innermost layer of the esophagus. It's composed of three major layers. From outside to inside, they include the epithelium. The epithelium faces the lumen of the esophagus. Then the lamina propria, which is made up of connective tissue, then the muscularis mucosa. Then the epithelium of the esophagus tends to be lined by non-characterized stratified squamous epithelium. This is distinct from what we see in the rest of the GI tract, which is lined by columnar epithelium, simple columnar epithelium. So the esophagus tends to be distinct from the rest because it is lined by non-characterized stratified squamous epithelium. When we drop down to the second layer of the esophagus, the submucosa is found beneath the mucosa layer. It's composed of loose connective tissue that contains large amount of collagen and elastin fibers. It's highly vascularized, and most importantly, it contains one of those enteric nervous system components I mentioned, known as the Meissner's plexus. The reason why this plexus is present in the submucosa is to stimulate very important tuberoactinal glands in the submucosa and help them in secreting large amount of mucus. And the mucus would assist in some of the functions of digestion within and absorption within the stomach, within the esophagus. So the third layer of the esophagus is the muscularis externa. It is found underneath the submucosa. It's composed of two major layers of muscle. One of them is an inner circular muscle. The other is an outer longitudinal muscle. So the muscles tend to either be striated or smooth. Usually we see that the proximal one-third of the esophagus tends to be made up of striated muscle. The distal one-third is made up of smooth muscle, and then the middle tends to be a combination of both. In the muscle layer of the esophagus, the muscularis externa, between the two circular and longitudinal muscles is the second component of the enteric plexus, and that's known as the alveolus plexus. The alveolus plexus is present for the function of motility. So just as the Meissner's plexus helps in stimulating glands to produce secretion, the alveolus plexus helps in producing motility across the muscles of the muscularis externa. Finally, we have the adventitia. The adventitia is the outermost layer. It's made up of dense connective tissue. It contains blood vessels, nerves, and lymphatics that helps in supplying the outer part of the esophagus. So let's talk about some important clinical significances. First, in the congenital anomaly we know as the esophageal fistula and esophageal atresia. I'll show you pictures of how this looks like. This is when there's an abnormality in the development of the entire esophagus. We'll talk about that in a separate slide. Then we have the concept of gastroesophageal reflux disease. This is when the lower esophageal sphincter is not functional, and as a result, we have a reflux of gastric contents into the esophagus. This can lead to acid destroying the lumen of the esophagus, leading to what we call the Barrett's esophagitis. And what practically happens is that the continuous exposure of gastric acid to the lumen, to the mucosa of that area of the lower esophagus, tends to change the epithelium from being a non-characterized stratified squamous epithelium to a columnar epithelium, and as a result, this can predispose that region of the esophagus to the formation of neoplasia, which we know as esophageal cancer. This is an image that depicts for us the congenital anomaly we know as the tracheoesophageal fistula and esophageal atresia. What you need to remember is that the commonest form of TOF and EA is when there is a proximal esophageal atresia shown here and a distal tracheoesophageal fistula here. So once this practically occurs when there is an abnormality in the process of separation of the esophagus into a ventral trachea and a dorsal esophagus. In this case, you have the distal part of the esophagus being attached to the trachea, and then the proximal part of the esophagus ending as a blind pouch. And that concludes our module on the esophagus.